is the panel discussion on anesthesia, patient safety, and Indian diversity. For this, to moderate our panel discussion, I would like to request Dr. J. Balavenkatassubramanian from Coimbatore, and his brief profile I just read out. He is MD, Senior Consultant and Academic Director, Department of Anesthesia and Perioperative Care, Ganga Hospital and Medical Center, Coimbatore, India. Currently, he is also Secretary, World Federation of Society of Anesthesiologists, and a certified CTLS instructor and course director of International Trauma Care Indian chapter. And he is also invited faculty of various world congresses. He had delivered more than 600 lectures nationally and internationally, and had authored books, 6 total. And with this note, I would like to welcome Dr. J. Balavenkatassubramanian to carry the session forward, our panel discussion. Sir, over to you.
Yeah, thank you so much, Ms. Devdatta Das, for that introduction. And I would like to thank Kaho for making it a very special day for all the patients across the world who are about to undertake a surgery, because sessions like this are extremely crucial, and for us to make sure that no perioperative morbidity or mortality happens because of a possible gap in anesthesia services in the perioperative period. So I thank Kaho for making this happen. And I bring to you greetings from Ganga Medical Center and Hospital, Coimbatore, an organization which is very closely associated with Kaho. And I also bring to you greetings on behalf of the Indian Society of Anesthesiologists, which has partnered with Kaho in this continuing quality education series. And I also bring to you greetings on behalf of the World Federation of Society of Anesthesiologists, for whom this organization I serve as secretary. I would like to congratulate and thank all the anesthesiologists, anesthesia technician, paramedical staff working in the operating room for doing what they are doing today. And I consider anesthesia as a specialty which is the backbone of any hospital. And I also probably think that we need to call anesthesia as the mother of modern medicine, because this is the only specialty where the specialist reads everything about all the medical fraternity, right from the newborn to geriatrics, to obstetric anesthesia, to cardiac anesthesia, to pulmonary anesthesia. They give anesthesia to a patient who has got liver failure, renal failure, lung failure. So, and they read about vastly about everything. So it's very crucial that this session highlights the importance of anesthesia services in the society and in the hospital especially. And today we are going to have a very vibrant panel discussion on anesthesia patient safety in Indian diversity. All that is true about India is untrue. This is what Mark Twain said several years ago when he visited India, and it holds good today. We need to thank for the advancements that we have made, phenomenal advancements we have made in doing major surgical procedure where we are inferior to none globally. At the same time, because of the huge population, different in the terrain, different in the infrastructure available, still we have issues. And I think this panel discussion would bring forth those challenges and the possible remedial measures that we could offer to our surgical patients. I'm extremely happy and delighted to welcome the very esteemed panelist in this panel, Professor Dr. Rakesh Garg, who is currently the editor-in-chief of the prestigious Indian Journal of Anesthesia and working in a very apex tertiary care referral institute in this country, the All India Institute of Medical Science. Welcome you, Professor Rakesh Garg.
Thank you.
I'm also very happy to welcome Dr. Pankaj Gupta, who is a National Governing Council member of the Indian Society of Anesthesiologists from Nasik, who has done a lot of work for the upliftment of safety in private practice in this country. Welcome to you, Dr. Pankaj Gupta.
Thank you, sir.
I have great pleasure in welcoming Col Suresh Babu, who is a senior consultant anesthesiologist from the very esteemed RR Army Hospital, New Delhi. Thank you very much for joining us amidst your busy schedule. Welcome to Colonel Suresh Babu. Now I have great pleasure in introducing Dr. Chaoba. Chaoba is also the governing council member of the National Body of Indian Society of Anesthesiologists. And we wanted him and his opinion because he represents the northeastern part of India, the Seven Sisters, where the geography and the terrain is very different. So today's panel is a mixture of having an anesthesiologist from a tertiary care referral center in private practice in the northeastern area, where we call it as a remote location, and the precise anesthesiologists who work for the Indian Army, who do a lot of work in disaster management. Professor Rekha Das, who was supposed to join us, may not join us today because she's unwell. Now, the first question that I would wanted to ask is to Professor Rakesh Garg. We had two interesting sessions before this, but a panel discussion brings in the reality. We have guidelines, we have several protocols. But a panel discussion brings forth the ground reality, the truth, and the ability to follow the guideline and the gaps that exist and how to fill it up. So may I ask Dr. Rakesh Garg, sir, you work in a very busy tertiary care referral center, an Apex institution. Do you think that still we have scope to improve in terms of anesthesia patient safety? Are there any gaps? And what is your assessment of gaps in major institutions of this country? Over to Dr. Rakesh.
Absolutely. I fully endorse that we have to provide a safe perioperative care to all our patients. Even one complication or one adverse event which could have been avoided in millions of cases needs to be taken care of. So when we say we are working in a bigger institute, simultaneously probably increases the responsibilities also, because we are getting referred patients who may be having higher amount of comorbidities. Probably they will be undergoing major complex surgical procedures. Maybe sometimes because we have a long waiting list, being the tertiary care referral centers and government funded centers, we have a huge number of waiting list and huge number of patients coming to the OPD. So looking into all those scenarios, if we see the journey of patient, which Dr. Murli nicely mentioned, from preoperative care to discharge and follow-up, there can be some inadvertent gap which can happen. For example, say a patient comes to a PAC clinic, we are assessing the patients. Say we have to spend some time, say 30 minutes, 20 minutes to have an holistic assessment of ASA physical status 3 or 4 patients. But sometimes because of the pressure of finishing up more cases, we may spend less time and probably we may miss some of the things. So that's why here we require something called a fixed protocol and the division of work. We need to have something screening, something fixed format, some process of filing them into the file so that each step is taken care of. Similarly, if we talk about the other factors like the organizational influences, I think this is what we need to learn from our mentors. A person having an experience of 20 years may not be equivalent to an experience of a freshly entered 3 years of experience, though at times they may be managing the similar type of cases. And here comes the mentorship and the supervision, which is equally important. So these type of supervisory factors also needs to be incorporated into a system we are working, where a system, something called call for help, should be integrated into the system in a robust way. The other aspect is about the availability of equipments and the different format and different companies which are coming up. And this also needs to be seriously thought of. When we are using an equipment from a single brand or a single company, it becomes very easy for us to use them. But having a wider variety of patients using multitude of equipments and drugs, sometimes there is some confusion which happens, which leads to some amount of complications. For example, we are very comfortable with one type of video laryngoscope or with one type of fiber optic bronchoscope, with maybe at times disposable. But if it changed to the other company, other brands, they will have different connotations to it. They will have different requirement to it. And if you start using them on an emergency situation, in those situations, it may lead to increased amount of complications or inadvertent issues which can happen in these group of patients. So these are the concerns that we need to look for. And the other, I will say, safety concerns, one of the very important factor is the communication. Especially when working in a higher center, we have to communicate so many things to the patient. We cannot say no to the patient. We have to get the surgery done, because being an epic center, we have to get the complex surgeries done to these patients. But simultaneously, it is our duty to communicate with the patient on one end, and to our team members, the complexity of the situation, and make a robust plan by keeping all the stakeholders into loop. This sometimes becomes challenging because of the overburdening of or involvement of different stakeholders or different team members into the discussion section. And this is one of the major issues that also needs to be taken care of. And we need to have some screening tool or a triage tool so that we can at least identify a certain group of patients which requires a group approach for making some management. And that's we do sometimes into our oncology patient, we have tumor boards and we take a combined decision. Similarly, something has to be done in a perioperative care for these patients so that we can come to a very robust plan for the perioperative care for these patients. So I think these are a couple of things which is important, which I think from my organization, which comes to my mind and we probably can improve on by taking some remedial measures.
Yeah, thank you so much, Professor Rakesh Garg, for sharing this concept. So it clearly indicates it's immaterial of where you work. Even if you work in a tertiary care referral center, still there are gaps existing, and you enumerated the gaps. Thank you so much for doing this. Moving from a tertiary care center to a private practice, where the private practice is not defined in this country. It can be one monitor, one anesthetist, no help, to a hospital, private hospital, which has got all the infrastructure. So it is absolutely diverse. It becomes too challenging for the anesthesiologist practicing in private work, because every single hospital that he visits has got a different infrastructure, different help, different resources. So he has to be so competent to manage all that, and the gaps are huge. May I request Dr. Pankaj Gupta, who has been in private practice for 3 decades, to explain to us the existing gaps in private work in diverse situations in India.
Thank you, Dr. Balavenkat. At the outset, I would like to thank Kaho for having this sort of a discussion, because I feel this I've been talking about for the last so many years, and Dr. Murli came out with all sorts of guidelines, but I was felt a little sad that I did not see the ISA guidelines being mentioned in the so many guidelines that he came out with. So I've sent him a copy about it. Dr. Murli, I'm sure you'll acknowledge that. You already acknowledged it. Private practice in India is a very different ballgame altogether. In 91, when I started practice, I didn't even have oxygen or even suction machines in some places. Based on that, today I feel happy that we have managed to improve this work culture in the country. In 2017, we came out with minimum standards in every operation theatre in the country. Unfortunately, what has happened is every OT is different. OT in a small town, and OT in a city, and OT in a major town again is very, very different. In a recent survey, I found that about 75 to 80% of the operation theaters that came under the survey, only 75% had central oxygen. So you can imagine in private practice, when you're going to every operation theater, it's very imperative to go and have a look at the operation theater, what is available and what is not. Probably I feel what is not available is more important in present day situation. Believe me, in my initial days of practice, I've been asked, have you got a suction machine with you? So private practice, as I said, is a very different thing. Thanks to our efforts, we have come down to a place where the differences are coming down. In a recent survey, I found that most monitors have become a basic thing. Of course, in private practice, ETCO2 is a big problem because we had not made it absolutely mandatory in 2017. But the new guidelines which we are coming out with in the next few months will definitely have ETCO2. Other thing is being a one-man show is the biggest problem because right from your PAC to the putting an IV line to monitoring the patient intraoperative to maybe sometimes you're ventilating the patient if you don't have a workstation and post-operatively extubating and shifting the patient to the ER is all the responsibility of one person. So we have each anesthetist has to decide his own level of what type of cases he wants to manage in that particular OT. I mean, I always have graded my surgeons as I have graded my OTs that I work to. Fortunately, today I have managed to work in the best of centers in the city. All are individual nursing homes. Some corporates I do visit once in a while, but there, as even Dr. Rakesh, even Dr. Murli said, there is no problem of having adequate staff. The big problem that in private practice it comes in case your patient has a cardiac arrest on table, your surgeon is washed up. There is no proper personnel to assist you. So that's why I believe that your OT staff or paraphernalia or the sisters, you have to train them yourself that this is what I expect from you. In case a patient goes bad on table, in case I have hypotension, this is what I want. In case I want assistance in CPR, this is what has to be kept ready by you. So that's why it's very important for a private practitioner to gauge and judge the operation theater and only then decide whether he wants to give anesthesia in that particular OT, or he should be bold enough to inform the concerned surgeon that please let's not do this patient in this OT. You will shift to a higher center. Every private practitioner has to have a tertiary care center in case of a problem, and you are forced to shift a patient from the OT occasionally from the operation theater table to the tertiary care center. And I mean that's a big thing which we really have to be ready about anytime in private practice.
Thank you so much, Dr. Pankaj. There are a few things which clear take-home messages that came out from your talk. Number one, it is the duty of the anesthesiologist to train all the paramedical staff and the anesthesiology technicians inside the OR, including the surgeons, on the basic life support and advanced cardiac life support. That's a big take-home message, which will preserve several lives. That's number one. And number two, I think it was a clear guideline to say that every private hospital should have a lifeline with a nearby tertiary care referral center to, in case of an eventuality, then you have an access to a center which can help to make the patient survive. I think that were two very nice take-home points, I think, which all of us will note down. And if every private hospital for part of cargo who are here today, I think that's a very nice suggestion to have a lifeline in a memorandum of understanding with a neighboring unit, which is a tertiary care center, which can treat critically ill patients. Thank you so much for your inputs. From now there, we go on to Colonel Suresh Babu, because we chose each specialist in the panel today with different backgrounds and different thought process, different mental models. So Colonel Suresh Babu, working in the Apex Army Hospital, the RR Hospital, and having a part of, you've been in the part of several disaster programs. You were there to help, including earthquakes, national, international. So you bring inside with you a lot of wealth. And what are the gaps you think that exist according to you, which we need to address?
Yeah, Fortunately, I work in a large referral hospital, but my takeover points is the approaches for risk reduction and patient safety is errors. Errors could be a communication-based, action-based, or decision-based. And the challenge which I feel, and when I introspect, every 3 years, the paramedic is posted out to a different center. So it can happen that I'm working with a paramedic or a technician who comes from far-fledged high-altitude area who's not seen a procedure being done to an experienced technician. So that is why they say the competence, and second one is the briefing before the surgery. Next is identifying it, because most of the service hospital are hugely spread out and the OR is in one block. So identifying a patient and a procedure. And the third important thing is the OT preparedness, because large referral hospitals, every subspecialty has 2-3 theaters each. So on a single day, you would be doing a renal transplant and you would be doing probably a hip replacement as well. So OT preparedness is very, very important. Fourth, the safety checklist, because the mind is sometimes it so happens you have to manage a third theater as well, as I did day before yesterday with the mass casualties. So the team leader or the consultant anesthesiologist should be very, very up and active. 4 is peri-procedure safety. Peri-procedure safety, when I mean the medications, drugs, fluids, dilutions, availability of cardiac drugs. Fifth is the medication safety, especially when you have when you are managing 3, 4, 5 different OTs, at least 2, 3 OTs. 5 is most important, and the challenge which I faced in my 2.5 decades of service here is the blood transfusion and the components. What happens is the blood bank is almost 10 minutes walk. And once you are in need of a regime where it warrants a massive blood transfusion protocol, there's always wanting and patient is deteriorating. So that's the challenge which I always face. And especially when I'm doing a pediatric or a neonate case, there is no time. Last is preventing falls and injuries, because geriatric patients, so that SOP should always be in place. So what I do is the previous evening when I get the OT list at 4 o'clock the previous day, definitely I'm going to spend 15 to 20 minutes planning for each operation theater. So briefing and debriefing is extremely important. For example, today I've done endoscopy, 2 endoscopy suits where I've done 12 cases. So you have one resident managing and one consultant with 2 technicians. It is very, very imperative that you are alert and always be available. So these are my sum up points.
Thank you so much, Dr. Suresh Babu. I think you also gave several insights. And from your submission, it becomes very, very important to note that the paramedical staff and the anesthesia technicians are as important as the anesthesiologist per se, and they have to be cognizant of the case that is being done. So which clearly indicates that there should be a discussion between the anesthesiologist and the anesthesia technician about the requirement for the next case. So he is mentally prepared. So I think that's a very important note that you suggested. And also it is very important that when you hand over and take over between 2 anesthesia technician or between 2 anesthesiologists, both in the morning and the evening, I think that's a very crucial time when things go wrong, and documentation of what has been done has to be very lucid. I think you brought in certain very important components. Now, I will ask Dr. Chaoba, who works in the Northeast. So now here we heard Dr. Suresh Babu saying that the blood bank is 10 minutes away, and that's a challenge. But where Dr. Chaoba works, maybe the blood bank may be 10 kilometers away, So we will like to have the perspectives of Dr. Chaoba. Over to you, Dr. Chaoba.
Thank you, sir. So, coming to the Manipur and the Northeast, we are geographically difficult areas. But recently, I just want to before going back to the blood bank and others, I just want to narrate a story. Last week, only 2 weeks back, one of the senior anesthetists was giving an anesthesia for a young lady around 35, 40 years. So they are doing the left chole plus left hysterectomy. Left chole plus left hysterectomy, and they did the surgery at another surgery after in the post-op area. Patient was telling she was completely aware of the anesthesia, even the cutting the skin, everything was totally aware. Totally aware. So what happened was so I'll say it's more like Col Suresh said, like that support staffs that they didn't check the machine properly. Your vaporizer was not working. They didn't know it. And your gas monitoring, even though it was there, initial gas monitoring system was there, they didn't connect it because they want to save, like ICME filters your price. That is around 400, 500 rupees. They want to check it. They didn't put the ETCO2. So it's a complete, this one. So patients suffer a lot. So that patient was totally, it's a very horrible experience for the patient, is totally conscious throughout the your operation. So they call me at the post-op period, what can we do it? So I take a closed door meeting with all the hospital owner and the doctor, main surgeon and the anesthetist, the senior, and we discuss that. So it should be, say they can cut on the anesthetist fee or surgical fees, but not on the monitoring thing. And they should hire more of your skill, your OT staffs. So that's the thing. So I'll say, when we say about the safety, it's not about your monitorings and others. If even though you might be having a good monitoring system, but if you don't know how to use it, that is the problem. That's the problem. So carelessness, human factors, the attitude of your hospital staffs are equally important. And coming to the updates, the latest update they have to follow it. And what we face in the Northeast about the updates. See, NHS, okay. Some of my colleagues go for the conference, this thing, that thing, but more than 50-60% of the NHS can't go for a update. Even though I'm in the Imphal, so Manipur is now whole issue was there. So if I'm doing a CME at Imphal, those people in the hill, they can't come down. Even though to come to the CME for the evening, they have to travel for 3-4 hours to attain my areas. So it's a very difficult for us to update the thing. Now coming with and more about the network issue is there. Internet network issue is there with the periphery. So that's another issue we are facing. And coming to the blood banks and others, we have got only one blood bank in the Imphal. I mean, 2 blood bank here in the Imphal, 1 in the district hospital. So 3 we are trying to manage with it. So all the patients from the periphery, they try to bring it here. So it might take sometimes 4 hours, 5 hours, 6 hours to bring the travel to the Imphal, even though it's very small area, but they try to bring to the area. So this is a difficulty we are facing. So.
Thank you so much, Dr. Chaoba, for enumerating a scenario. And it's very important, as you rightly said, it's not just having the equipment, but to know how to use the equipment, number 1. Number 2, monitoring. The cost that is involved, if that is considered and you didn't use it, I think that was another big crime. I think that was another beautiful point that you brought in. And the third important point that you brought in, which I think we need to focus as a society, is the difficulty to update for those who are serving in rural areas and remote locations, because that particular city or the village will have only 1 or 2 anesthetists. So they are crucial and they can't take leave and they can't attend any conference. But if they wanted to attend a virtual meeting, again, it is not possible because your network is not working well. So I think that's such a very valid and important point that all of us need to focus and to see how to come over these two challenges. So we had such an insight from the diverse practices in this country, and we need to get some solutions. Like this panel discussion has brought out certain important components, and we will try to address this through CAHO. And also we are trying to come up with the Anesthesia Patient Safety Forum of India. We're going to come up with a book where we will incorporate all these challenges. So now halfway through this panel, I would wanted to go for real-time scenarios that you would have come across. And what did you learn from that? I would wanted it to be very precise for all of us to understand and to be to the point. So real-time scenarios, a complication, whether you have seen yourself or heard or have been a mentor for someone who called you. So may I start with Rakesh Garg to enumerate a scenario that he faced or he came to know, and what are the remedies?
Absolutely. I think this is important, sir. And it has come to my knowledge through various persons working across various centers. And also there is a nice article which has been published recently into Indian Journal of Anesthesia, the wrong administration of the drug across the wrong route. It was a good article wherein they have demonstrated that the intravenous induction agents have been administered into a central neuraxial blockade. So I think these type of the drugs across the wrong route is absolutely disastrous things. And sometimes it has been seen, though it was on the verge of happening, I have seen it personally at times, that the drug which we are supposed to give through the epidural route as a continuous infusion accidentally was being connected to the central venous line, though we could save on time. So these drugs.
Sorry to interrupt you, sir. What is the root cause analysis and how to prevent this? Because it's happening again and again. So what are the suggestions that you would give to prevent this from happening?
So we need to be very careful. The person who is preparing the drugs should be appropriately labeling them. For example, sometimes dexamethasone is also dex and dexa is also dex. So it creates a confusion. So labeling should be appropriate, probably a printing stickers with appropriate dosing. The person who is preparing the drug should hand over directly to the person concerned.
So now again I interrupt. Whom do you think is the right person to prepare the drug? Is it the anesthesiologist or a qualified anesthesia technician or somebody who is not qualified, who has been working in the theater, whom you believe? So what is the ideal thing that is to be done?
So the most ideal will be the person anesthesiologist should be filling the drugs, at least the drugs which are of critical level, like for example, the opiates, the anesthetic agents, they should be loaded by the anesthesiologists themselves. But yes, considering the workload, if it is being done by the qualified technical
again,
staff,
I wanted to interrupt. Is it the workload or the attitude?
It is the attitude, sir, because I remember from
so
my
I like the statement. Yes.
Because I remember my teachers have told me that you reach the operation theater 5 minutes before and load your own drugs, prepare your own drugs, set your trolley set. I think that's the basic thing we need to remember. And secondly, recheck it. Because when we are putting in the tray, the different drugs will be there. And usually they may not be labeled because of the sterility technique. So again, we should be cautious that we have a markup and label them appropriately so that when you are using them, you are using it appropriately. Third thing is, even before administering them, recheck it once again before you administer. So these are the attitudinal and your practice pattern that would avoid these type of complications during the drug scenarios.
So I think the take-home message is the drug which was supposed to be given intravenous was given intrathecal, and so wrong drugs being put on the wrong route. And I think all those who are attending the session should believe that this is happening even today in large numbers. And I think the most important thing is, even if the anesthesia technician loads the drug, it has to be in front of the anesthesiologist whom anesthetizing. The ampule or the vial is shown to him, then the drug is loaded, and one by one it is labeled. It is not loading all the drugs, and then suddenly you get confused which one you loaded in. You initially say 2 cc, 5 cc, 10 cc. It also depends upon whether you're working in the daytime, on whether you're doing a night duty, or whether you just finished the night and starting an early morning case where your cognition is very poor. So I think that's something, a very important take-home message that we would take home today. So now coming to Dr. Pankaj, can you enumerate a case that you have come across or you have seen and remedial measures?
Two cases I would like to discuss. One about the anesthesiologist in private practice always loads his own medicine. This is a dictum for me in every operation theater that I go. No assistant or no OT staff is supposed to put any syringe which he has filled and keep it on the boils machine or on the workstation. So I've seen intrathecal tranexamic acid, myopyrrolate, NTG, all three being given. So I realize that I'm better off as a private practitioner. I'm loading my own drugs always and not waiting like Dr. Rakesh. One interesting case which I would like to enumerate is I have witnessed anaphylaxis to diclofenac. At the end, when the cesarean section at closure, we usually had a trend of giving intramuscular diclofenac. And believe me, within 5 minutes of me giving it, I suddenly saw the ECG going flat. The patient started complaining of some somewhat of itching in the both the arms, and suddenly she just stopped responding. And suddenly I could see the neck swelling. So the first thing I did was I picked up a tube and intubated her. And believe me, I saw the larynx swelling up in front of me. Fortunately, I could put across the tube, ventilated, and then started the resuscitation. All the drugs, adrenaline, steroids, everything had to be given. For 4 hours, we were managing that patient in that private nursing home. And after that, I involved a physician, a critical care physician. Then we both decided we will ventilate the patient because the edema that I had seen was really something I had never imagined I would see in any larynx. We shifted the patient to a tertiary care center, ventilated the patient post-operatively. I was continuously in touch with the intensivist there, and next day afternoon we extubated that patient. Believe me, this anaphylaxis was a lifetime experience for me. How to deal with the relatives, how to deal with the management, shifting a patient. Many times these days, tertiary care centers may not allow a private patient to be shifted because they are, in case of a mortality, they are not comfortable having shifting a serious patient. So these learning experiences, I feel, teach us a lot, and I feel all of us should have that plan B in case of any eventuality in any operation theater.
So thank you so much, Dr. Pankaj. So the take-home message is, even when you are working in a private, the minute you noticed an anaphylaxis, I think one, to prevent hypoxia, second is to prevent a cardiovascular collapse. So I think you should do it. And I really like the way you said that you stabilize the patient. Then you thought that it is not prudent to manage in your center, and you move to a center which is offering a tertiary care critical support. So this re-emphasized the point that patients accept a complication, but they will not accept negligence and the attitude of the doctor in this scenario. Here, you took them into confidence, you told them that what is a problem, and then you took up the responsibility of shifting the patient. You followed up the patient and you saw that the patient was extubated. I think this attitude is possibly one that every one of us should do, irrespective of where we work. Thank you so much for that insight and for openly admitting your own complication and how you dealt with the complication. So it sends a clear message of the attitude. Now, may I request Dr. Suresh Babu to share a complication and the fallout and the lesson learned?
It was winter of 2024. And one Monday morning, I was posted in the joint replacement theater. Probably the day prior or the week prior, I was not in the town. And as usual, Monday, we started work. We did it simple, I mean, it's a normal TKRs, a couple of THRs. And as a habit, I was doing my post-op rounds before I go home. Then the sister told me, sir, could you have a look at this patient? Because Generally, for a knee replacement or joint replacement, the most common complication is either pain or fever. But she sounded me, sir, this lady has a decreased urine output. Then it alarmed me. It's the same protocol which we follow in every patient. Then I was more inquisitive. Then I started seeing how much fluid was given, how much was the urine output. Then I told the sisters, can we repeat a blood test? So to my surprise, I see azotemia. It's a simple, normal ASA grade 2 patient, no comorbidity. Why should the patient land up in azotemia? Then it made me more inquisitive. I said, did we have any other patients who have this same sequence of events? So the sister said, yes, sir. Last week we had a couple of patients who had the same cycle. Then I was more inquisitive. Then I said, came back, and the next day, early morning, I came back and checked what all possible drugs would have been given in this patient. It's the simple, standard, simple 2 ml or 3 ml of bupivacaine and the IV. Then I went into which company IV fluids, or what are the IV fluids which have been given. So when I inquired, what are the IV fluids which have been given? Because our institution, we only buy 2 or 3 companies, either BD or B Broad. Nice, I mean to say, reputed companies. But it so happened that week, the next stock was, the supply order was given, but the dealer didn't supply. So to address this short gap, we purchased in a local market. Naturally, any institution will resort to this activity. So then again, I brought all the fluids, whether it is ringer lactate, 5% dextrose, normal saline. I started doing a Google search. What is the reputation of this company? To my horror, one company has been banned in 17 states and 3 countries. Then my management experience from IIM Calcutta, fortunately, I contacted the Lal Path Labs. I said, I want to do an analysis. When I did the toxicological analysis, rightly so, the company which was banned in 17 states had rank toxic. The results were there. And that is why the patient was having azotemia. So immediately I notified the administration. We did the checks and balances. And it was a great learning lesson that the patient was managed well. But still, that's where quality comes into play.
So thank you, Sam, so much for sharing a live story. And it becomes important also to notice that a company that has been banned in 17 states, how can it still exist? So
Exactly.
This throws a new challenge, and I think the point is well noted and taken. And I think both as an Indian Society of Anesthesiology and CAHO should take it up earnestly to see that such products should never be there. And also it becomes important to put safety checks by the purchase department. And the purchase department has to possibly talk to the professional involved on whether this product can be purchased because of the shortage. That's a very valid point, and that was an excellent narration. Thank you so much for doing it. Dr. Chaoba, it's up to you now to tell the case scenario, the lesson learned, and the complication.
Yes, good evening, sir. Sir, almost 20 years back, I just want to, when I was freshly passed out from the college and I was doing the anesthesia. So I came across a case of can't ventilate, can't intubate. That is the first time I saw it, and I don't want to see any other again. The reason being, so my friend from the ENT said, Chaoba, we'll do a small biopsy of the vocal cord. So only vocal cord biopsy. So he said, okay, no issue, we'll do it. So he said, okay, how is it? So he saw by the doses, he saw by the indirect laryngoscopy. He said, yeah, it's a supraglottic only, we'll just take a biopsy and come out. 5 minutes, 10 minutes work only. I said, okay, no issue. So take the patient, I'm coming. I didn't examine the patient. I said, I'm coming. So straight to the OT. I didn't do any PSC, straight to the OT. Okay, take the patient, we'll do it. So we do it. So once I was inside the OT, I can see some stridor was there. So I said, some stridor is there. He said, no, that is supraglottic growth. So that will be some narrowing will be there. So stridor is there. Okay, so how long take? 10 minutes. Okay, I said, well, let's start it. So we put on monitors. give propofol. Once you give propofol, ventilation was a bit difficult. Then I give, okay, I think maybe reduction is no good. Give this colon. Once we give this colon, everything collapses. Then I just hold the laryngoscope. I try to intubate the case. So to my horror, what happened was that the size 5 tube can't go in. I can see everything. The growth was extending from the infra coming all the way to the supraglottic area. They cross it. So the tube which I'm having, even though I can see the vocal cord, I can't put it. Saturation was dropping. So around 20s, I can hear it. 20s, I just look at 20s. I told ENT, I just do the tracheostomy. With the tracheostomy, in the nick of time, we can shove the patient. We shove the patient. So to my horror, that's what the biggest mistake I've done in my life till now. Why I said till now, because when I came inside the OT, I noticed that patient has a stridor. I didn't work up for the stridor. How much is the narrowing, everything. So I didn't do the PSC. I didn't do the workup of the stridor. We didn't do it. And the ENT surgeon didn't do the CT scan to see the extent. So my thing should be there. All the anesthesias, we should have some PSC should be there. All the time, some workup should be there. If you fill it by phone or by this one, you should be doing the PSC properly. Should do the PSC. So that's the mistake I've done it. But we can somehow we save the patient because he is the ENT surgeon. If the ENT surgeon is not there, I could have lost the patient. And one thing from that moment, I thought that I should learn how to do tracheostomy. Those days, I thought no one does that. Very few people does your percutaneous tracheostomy at that time. So I thought from almost 20 years back, I said, no, this is the moment I should learn about the tracheostomy. So I started learning about tracheostomy from that thing. So every anesthetist should know how to do a tracheostomy, number one. Number two, every case we should do the PSC properly.
Thank you so much, Dr. Chaoba. I think very few people admit in an open forum about a complication that they faced. And thank you so much for being courageous enough to present this. And we had such a lovely discussion, lively interaction. And there is a question in the chat box to Dr. Suresh Babu. What was the problem with the IV fluid?
It was, I mean to say, there was, when we did the lab analysis, because the administration was trying to say that there was some problem from the anesthesia side. That's where I got very, very curious and involved, and I was the lead investigator. The report says that first is it's a local company which is across the Yamuna River, one, and two is it says it contains traces of toxic elements.
Okay. So the answer is very clear to the chat box question, and another important question in the chat box, which has been asked by Dr. Pranay. He's asking, is there a list of drugs available which is mandatory before starting an operation in the operation theater? In other words, a checklist of all the essential drugs that is to be present inside the OR to treat a complication. I think that's an extremely good question. And as much as I know, is there a formula or a guideline by any organization that's been given? Anybody can answer. Dr. Rakesh, do you want to take this?
Yeah. Yes. So all hospitals have a drug list which says the essential drugs and drugs to be required. So like in my theaters, usually every yearly we update the list and keep it. And this works on the background of a WHO essential drugs that should be there. So what we do is in my operation theater, an emergency trade drug is separate, which contains these drugs. And similarly, if you see the government of India, they have also issued these guidelines of the essential drugs to be available inside the hospital. But of these, you have to decide which drugs should be there into your operating rooms. And the list can be made from those comprehensive lists available with WHO and Government of India.
Yeah, thank you so much. I think that was a very lucid answer that the WHO drugs that needs to be kept in the OR. And I think every hospital should make it mandatory. They keep it. Just not only that, they also keep it exactly in the same place that every technician knows where it is kept. and never it is under a lock and key, whether it's day or night. And uniformly, if you have more than one theta, and every theta right-hand corner is adrenaline, means right-hand corner should be adrenaline. I think not only keeping the drug, but also keeping it in the right place. So thank you so much, Dr. Rakesh. And the last question, we will wrap up very soon. And the last question that is in the chat box, should we go into the principle of one theta, one anesthetist, or is it okay that one anesthetist, two theaters with technicians? I think that's what the question meant. And I would like to ask Dr. Suresh Babu to take this question.
If I see the my Monday list tomorrow, I have 11 surgeries, 2 theaters. So single anesthetist managing 2 theaters, or it can be 3 theaters also.
Okay.
Fortunately,
So, yeah, please.
Fortunately, what happens is over a period of time, like on Monday, I'll be managing urology and gynecology, but we have residents. So, and the mind is tuned for the last couple of years to manage multiple theaters. One is India is, I meant to say, a country where the skilled resources at a premium, number one. Number two is it's easy to said and done that if you have 30 theaters, you have to have 30 consultants, which is very, very difficult. So that's why the government of India trains people, and I say it's a teaching institution. We have the first year, second year, third year. So to the institution where I work, I am comfortable managing 2 to 3 theaters. If a single theater, probably I'll be bored. But coming to the medical legal aspect, there's a case which has happened in Hyderabad in Yashoda Hospital. The court, the NCDRC, has clearly given a direction saying that it has to be one anesthesiologist per theater. So it depends upon the institution where you work and how comfortable.
Yeah, thank you so much for that answer. And I think we had such a lovely discussion in far and wide ranging, not only the geography from where you all come in, from the diversity that you come in, we brought in a lot of important factors for this session, and absolutely amazed at the courage that you evinced in presenting the true cases. And at this point, a lot of take-home messages, a lot of learning points. I sincerely thank CAHO for doing this in association with Indian Society of Anesthesiologists. I thank the President, Dr. Vijay Agarwal, Secretary General Dr. Lalu Joseph, and the Chairman of the Division for QP in CAHO, Dr. Anuradha Pichmani, and Dr. Anita Shirley, the organizing chair for this session, for giving us an opportunity to open up our thoughts, share our challenges. And I think it's important that we need to work on the gaps and make sure that when we are around, we preserve every single life that we anesthetize. I think it's very pertinent and important for any of us, if we want to do, if we want to buy a shirt or if we want to make our hair, we try to go to the best in the city. So I think all of us have to introspect, whether we are anesthesiologist, anesthesia technician, or paramedical staff. The patient in front of you has given his entire life to us. And it becomes very important and pertinent that all of us completely focus, completely give the best to the patient, and also consider that every single patient whom we are dealing with are our own father, mother, sister, or brother. And if we get this into us, I think all the infrastructure lacunae, whether it's day or night, all this, the boredom of working, everything will go off. So the final take-home message is, we need to minimize the complications. And for that, the simple, most and important take-home message is, consider every patient as your father or mother. And I don't think we will do any mistake. Thank you so much for that lovely discussion and the opportunity given. Over to the moderator. Thank you so much.
Thank you.
Yeah, thank you so much, sir, for wonderfully moderating the session. And also sincere thanks to all the eminent panelists who had shared their experience and beautiful thoughts from their experience.